Hello everyone. In my today's class, I'm going to talk about chest x-ray. Basically, it's a chest x-ray tutorial class. I'm going to talk about how to see or read a chest x-ray. Okay, let's begin. So, this image is of a chest x-ray. Now, there are certain technical issues that also we should be knowing about chest x-ray. First of all, how to hold a chest x-ray. While holding a chest x-ray, we should remember that as if the patient is facing towards myself. That means my left hand side should be patient's right side and my right hand side should be patient's left side. Now, how to identify this? In most of the x-rays, a letter R will be written on the right side. So from the R, we can know that this is the right side. Secondly, you can look at the dome of the diaphragm. The right dome of the diaphragm is always, normally it is always slightly higher than the left dome of the diaphragm. The third thing is that in the left side, most of the time there will be presence of fundal gas shadow. Okay. Though in this x-ray it is missing, but most of the time there is presence of fundal gas shadow on the left side. So these are the few points by which we can know which side is right side or which side is left side. We can also look at the cardiac apex. The cardiac apex is always towards the left side unless it's a case of dextrocardia where the apex may be on the right side also. Okay, so these are the few points we should remember while holding a chest x-ray. Now, there are few important technical things that we should know while reading a chest x-ray. Okay, first of all, we should know the proper inclusion. Okay, by inclusion I mean when the chest x-ray is being taken, we should make sure that the film should include both the apical areas, okay, the apical areas and the costophrenic angles. Okay, next important thing is positioning. Okay, we should know whether the patient's position is correct or not. How to know that the position is correct is that look at the medial end of the clavicle. Okay, if the medial end of the clavicle is equidistant from the midline, okay, if it is equidistant from the midline, that means the positioning is correct. But in cases of improper positioning, it will not be equidistant. Okay, third thing is about the penetration. Penetration or proper exposure. Okay, how do you know the exposure is proper? That means there is no underexposure, okay, or there is no overexposure. Okay, so when you call it a proper exposure, if you can identify the intervertebral disc spaces, okay, this black shadow is of intervertebral disc spaces. If in a chest x-ray film you can see the intervertebral disc spaces up to 6 level, that means 6 intervertebral disc spaces, if you can see clearly, that means the film is of correct exposure or correct penetration. Okay, but if you can see less than that, that means the exposure is underexposure, or if you can see more than 6, then it is said to be overexposure. Okay, so this is how we know about the penetration or exposure. The fourth thing what we should know is that what is the view of the chest x-ray. Okay, view, is it a PA view or is it an AP view? PA view stands for posterior-anterior view. Okay. AP view stands for antero-posterior view. As the name suggests, posterior-anterior view means when the chest X-ray is being taken, the X-ray source is the patient's back faces the X-ray source. Okay, that means that will be the posterior-anterior view. How to know that the view is posterior-anterior or antero-posterior? If the view is posterior-anterior, then look at the clavicle. Okay, the clavicle the clavicle is usually a little horizontal comparing to AP view. Okay, and the ribs, okay, the ribs are a little oblique in case of PA view if you compare with the AP view, where the ribs are usually horizontal. Okay, and if you look at the scapula, okay, in case of posterior anterior view, the scapula lies wide apart from the lung field. Okay, whereas in case of antero-posterior view or AP view, the scapula overlies the lung field. Also, in case of a PA view, there is no apparent cardiomegaly or there is no apparent magnification of the heart. But in cases of antero-posterior view, there is apparent cardiomegaly as the heart gets magnified in case of AP view. So these are the few points, okay, to understand whether it's a PA view or AP view. Okay, we can know from the position of the clavicle, then from the ribs, okay, then from the scapula, and also from the heart. So these are the 4 points to differentiate between the PA view or AP view. Okay. Finally, we should see if the film is an inspiratory film, okay, or it is an expiratory film. Fine. So how do you know if the film is taken during inspiration, okay, or at the height of inspiration? When the film is inspiratory, okay, we will be able to see that the 6th rib is crossing the middle of the right dome of the diaphragm. Okay, and also we will be able to see the posterior end of 9th and 10th ribs. So these are the 2 points to know whether it is an inspiratory film. If the film, again I am repeating, if the film is taken during inspiration, the 6th rib, okay, the 6th rib, anterior end of 6th rib should cross the middle of the right dome of the diaphragm. And the second point is that we should be able to see the posterior end of the 9th, 10th rib. Okay. Otherwise, if it does not follow this, that means the film is taken during expiration. Okay. Why we don't want an expiratory film is that if the film is taken during expiration, again there is slight magnification of the heart. That means again there is apparent cardiomegaly. Okay, and the lung field also becomes shorter. Okay, this is all about the technical points while reading a chest X-ray. Okay, now let's see what are the things we are going to look for in a chest X-ray. Okay, so first of all we can look at the airways. Okay, by saying airway I mean first of all we can have a look at the trachea, whether the trachea is centrally placed, how is the carina, how is the bifurcation. Okay, we can see in this particular chest X-ray, if you look very carefully you can see the trachea. Okay, this is the trachea, and here it is getting bifurcated. Okay. So normally trachea is central in position, but there are cases where trachea will be pushed or pulled towards a particular site. Okay. In cases of pleural effusion or empyema thoracis, massive pleural effusion, empyema thoracis, all these cases will lead to pushing of the trachea towards the opposite side. And in cases of collapse, okay, trachea collapse or fibrosis, okay, the trachea will be pulled towards the side of collapse or fibrosis. Okay. But in cases of consolidation, that means solidification of the lung, or in cases of presence of any mass, that means any malignancy, the trachea, we expect that the trachea should be in the midline. Okay. So this is about airway. The next thing we can look for is the bony structures. Okay, we can see if the clavicle is normal, the ribs are normal, there is if there is any formation of callus or any lytic lesion or anything suggestive of fracture, all these things we can look for. Okay. Now the next thing we can look for is cardiac shadow. Okay. So what we should look for in the cardiac shadow is that if there is any cardiomegaly or not, if any particular chamber of heart is enlarged or not. These are the things we can know from PA view of chest X-ray. But for that, first of all, we should know what are the structures which forms the cardiac shadow. Okay. Now let's see the structures which forms the heart border. Okay. If we know this, then only we can diagnose the part of the heart, which part of the heart is enlarged. Okay. So this bulging area, this is formed by the arch of aorta. Okay. This area is formed by the pulmonary artery. In between the arch of aorta and pulmonary artery lies the aortopulmonary window. Okay. This area is formed by the left atrial appendage. And this larger part of the left heart border is formed by the left ventricle. Now the right heart border, okay, this area is formed by superior vena cava. This area is formed by inferior vena cava, and the larger portion of the right heart border, this is formed by the right atria. Okay, this is about the heart, the structures forming the heart borders. So how do we know if there is cardiomegaly? We should take the cardiac diameter and the intrathoracic diameter. Okay, if the cardiac diameter is more than 50% of the intrathoracic diameter, that means there is cardiomegaly. I will show you how to diagnose the cardiomegaly. Okay, you should draw an imaginary line. Okay, first you draw an imaginary midline like this. Okay, so from the midline you connect to the farthest point of heart border on both sides. Okay, so left side, this seems to be the farthest point. Okay, and right side, this seems to be the farthest point. Suppose this is A and this is B, and we should take the intrathoracic diameter. Okay, suppose this is the intrathoracic diameter, that is C. Now if A plus B, okay, divided by C, if it comes to be more than or equal to 50%, that means there is cardiomegaly. Okay, this is how you diagnose cardiomegaly. There are cases, if there is a case of, it's a case of pericardial effusion, or if there is dilated cardiomyopathy, if there is left ventricular enlargement. Okay, in all these cases there will be cardiomegaly. Okay, now next thing we can look at is diaphragm. Okay, so we should see the domes of the diaphragm, and normally the right dome of the diaphragm, okay, is slightly higher. It is around half an inch, or near about 1 centimeter higher than the left dome of the diaphragm. Okay, if there is any discrepancy to this, that means the right dome is the left dome is higher than the right dome, or if there is any flattening of the domes of the diaphragm, so these will suggest some kind of abnormality. In cases of emphysema, both the both the domes of the diaphragm gets flattened. Okay, now the next thing we can look, which is most important thing in a chest x-ray, is the lung field. So we can look at the lung field, okay, and we can find out if there is any abnormality. Okay, this is the lung field, this is the lung field. Okay, if we can trace the lung field, we will know about the abnormalities of pleura also. Okay, if there is any abnormality in the pleura, we can trace it out. Okay, or and also we can see the lung field if there is any any opacity or any increased lucency. Okay, if there is any multiple nodule kind of thing, or multiple white patches. Okay, or if there is any abscess, fluid filled cavity. Okay, so these are the abnormalities. If there is any consolidation, if there is presence of any mass, okay, presence of fluid in the pleural cavity, that means pleural effusion. All these abnormalities we can find out from seeing the or examining the lung field in a chest x-ray. Okay, so this is all about how we read a chest x-ray and what are the things we should be looking for in a chest x-ray. Thank you.